Hello everyone, good morning. Welcome to one more lecture about hemostasis. Quite interesting lecture, and very important to understand what is like how different bleeding disorders they occur in the body, and of course to understand them we must know what is the normal process of what you can say the hemostasis. Okay. One thing which I realized that many students they don't have like you can say around more than 90% students they don't have any concept about hemostasis, and one of the reason is when they are going through physiology, for example, so they just you can say skip the details of clotting cascade and all the stuff so that because like that looks a little what you can say a little complicated, so many students they skip that. So I will try to explain not everything, of course I cannot, but the most important things which are used um, like yeah, clinically you can say to either control certain conditions or stop the bleeding disorders, or like what medications where they act and things like this. So anyhow, let's start. Like, what is hemostasis? He means blood, stasis to halt, so it is the process of forming clots in the wall of damaged blood vessels and preventing blood loss while maintaining blood flow in a fluid state, which is vascular system. Okay, so now why hemostasis is important? So see, in our body there is a balance between like there should not be a condition like this that blood should start forming clots in the blood. So if it will happen that like there will be clot formation, for example, so what is going to happen? Thromboembolism. And there should be not a condition like this that whenever, for example, someone have even a minor cut, so the bleeding is not stopping and the person is bleeding. Okay, so of course, like you can say, um, very important thing to understand here is normal hemostasis, okay, is a balance or occurs as a result of is a balance, or it occurs as a result of between you can say procoagulant and anticoagulant. Sorry, procoagulant and anticoagulant. Coagulant. Uh, Whenever this balance is disturbed, of course, if anticoagulation process is going to disturb, what will happen that there will be more and more and more clot formation, and what will happen, the person will start bleeding, and the persons can die because of excessive bleeding, or the bleeding can occur inside the brain, the bleeding can occur inside our vital organs. And when the clotting function is working too much, then what can happen, of course, there can be uh, clot formation in the blood, and the process which we call it as thromboembolism, again, which can lead to stroke, which can lead to pulmonary embolism, which can lead to DVT, or so on and so forth. So there should be a balance. Okay, and how this balance is maintained, of course, it is not so easy, of course, it's a complex thing. So stages of hemostasis: vascular constriction, then there is a formation of platelet plug, and then there is a formation of platelet clot, and in the end there is fibrinolysis. I will talk the same stages, in the slide, of course, everything is written, but I would rather go in my own way, like just to tell you how these things are occur basically. So, um, like, of course, those stages are correct, but like I'm just changing the names a little. Not I am changing like the books which I follow. So, what are the stages of hemostasis? Same thing in different words. Simply, the first stage can be called as primary hemostasis. Okay, and the second stage is called as secondary hemostasis, third stage is called as fibrin stabilization. The fourth stage is called as fibrinolysis. Okay. Um, see, basically, what is primary hemostasis? Uh, or like what is written over here is, vascular constriction, okay, plus formation of platelet plug. This is basically two things you can say, which are a part of primary hemostasis. Okay, so in primary hemostasis, the main thing is that two things which play a very important role. One is platelets, okay, thrombocytes, and the other thing is von Willebrand factor. If you know, all the clotting factors are formed in the liver, okay, except one factor which is present in the endothelial cells. Endothelial cells. Remember, whenever there is any damage to the body, what happens is the endothelium cells get the damage, and from there the blood started coming out. Okay, so let's take an example that someone had a cut. Okay, actually I don't what you can say, simply do these lectures, you can say, by using some special type of things, like of course, like there is specialized boards to do that. But I can tell you, for example, if this one is endothelial lining, okay, so like these are the endothelial cells, okay, this is a blood vessel. Sorry for bad drawing, okay guys, very 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 bad drawing. So of course, like for example, this is a capillary and this is our skin. So if there is a cut over here like this, of course the bleeding will start going out, right? So when the bleeding will start going out, so of course this one should be blocked, okay, this one should be blocked, or there should be immediate cessation of the bleeding, right? So what happens, like basically in this one, um, simply whenever there is there is injury over here, so this results in, you can say, release of different vasoconstrictors, okay, it results in release of various uh, vasoconstrictors, okay. So plus endothelial cells produce von Willebrand factor, and of course where is the platelets? Platelets, of course, they are running with here, with RBCs, with WBCs and platelets and plasma and everything. This blood is running over here, right? So platelets are over here, von Willebrand factor is over here. So as soon as there is cut, what will happen? First of all, vasoconstrictors will start secreting out, coming out, and von Willebrand factor is released. This one, which is present in the endothelial cells. So, because von Willebrand factors, they line the endothelial cells. Okay. Now, the important thing to understand here is what? Basically, it's the platelets which start attaching to the von Willebrand factor. Okay. As soon as the platelets come in contact with the damaged vessel wall, they start attaching to the von Willebrand factor. Okay. This process, you could say, see, this process is called as, oh, what is this, okay, I will simply go on my, guys, just a little lag. Okay, basically, this process is called as adhesion. Until and unless, I will fix this thing, listen to me. This process is called as adhesion. I don't know what's wrong. Here it is doing, but here this one is not. Oh, finally. Okay, so the process is called as what? Adhesion. Okay, what is this? What is adhesion? Simply, adhesion is what? Like the platelets adhere to subendothelial cells. Okay, with what? Via what? Von Willebrand factor. As I told you, that is released by what? That is released by the vessel wall. Okay. Uh, I can show you few diagrams as well for this one. For example, maybe this one. Oh no, this one is like for later use. So, okay, yes, this one. See, what will happen? The story is going like this way, that as soon as there is damage to the vessel wall, see the color of von Willebrand factor, the von Willebrand factor will start releasing. And this is, the endothelial wall they are showing, okay? Endothelial cells, and here is the blood. So von Willebrand factor is going to release as well as the collagen. And what will happen? That platelets are going to start attaching with von Willebrand factor, okay? As well as you can see, there is one receptor for what? The collagen. So one receptor is there on platelet, which attach with the von Willebrand factor. One receptor is there to attach with the collagen. Okay, so this is what is called as adhesion. Okay, now see. Okay, this one is again for later use, but I'm moving it. And the last diagram which I want to put is this one. Okay, finally, yes, this is about the drugs. When we'll discuss the drugs, we will discuss this one. Okay, so this process is called as adhesion. So what is adhesion? Simply, adhesion is platelets adhere to subendothelial cells via von Willebrand factor. Guys, remember these points, because all of them, they have some clinical application. That's why I'm talking about, like, saying this thing again and again and again. Okay, so adhesion is when the platelets bind to what you can say von Willebrand factor, and the receptors, by the way, which is involved in this one is the receptors which we are going to talk about is, wait, I'm going to tell you. Okay, yes, okay, so the receptors is in this attachment is called as glycoprotein 1b, glycoprotein 1b. Okay, so simply what is going to happen after this attachment is again, like, I'm making this thing you can say a little easier for you guys to understand. Okay, like you can say skipping a lot of basic information, which I believe, like, of course, is going to just make the lecture long, but we will not be having much, you can say, like, because all the conditions, you can say, which are related to platelet and on the medications which we used for them is basically related to these things, which what I'm telling you. Okay, after adhesion, there is one more thing called as activation. Okay, activation. Now, what is activation? that once the platelets they are attached to the von Willebrand factor, they are activated, and once they are activated, basically they change their shape and release two things: um, release of ADP, okay, and thromboxane A A2, okay. Again, this one adhesion is done, and now the platelets are activating. What they are releasing? Okay, they are releasing many other things. So that's why I'm telling you, saying you that I'm skipping a lot of things, but of course, like all these things are vasoconstrictors or somehow like are there in this thing. So ADP and thromboxane A2 is released, and what is happening? Like this process is called as what? Platelet activation. Okay. So simply platelet activation or activation is what platelets are activated, result in change of shape and release of ADP and A2. Okay. Whatever we are studying is basically primary hemostasis until now. Okay. And what is the what is the main goal of primary? What you can say uh, hemostasis is to make a, you can say, is to simply make a platelet clot plug. Okay. Then there is aggregation. What is this? Okay. Aggregation. Okay. Now, what is aggregation? Once this release of ADP and thromboxane A2 happened, basically more and more platelets they come together and they started getting attached together and they make a platelet plug. So you can simply say that recruiting of recruiting and aggregating of more platelets, okay, resulting in what? In formation of platelet plug. So see, this is all primary hemostasis. See, the damage is done. Endothelial cells, they will release what? Collagen and what? Von Willebrand factor. They will recruit platelets. Platelets will be activated. They will, like, there will be a release of ADP and thromboxane A2, which will activate the platelets, and more platelets will be recruited and they will form a platelet clot. This is called as adhesion, this is called as activation, and this is called as what? Aggregation. Okay. So what is the result of primary hemostasis? The result of primary hemostasis is simply platelet plug is formed. Okay. Platelet plug is formed. This is the result of primary what you can say hemostasis. Okay, guys, uh, the ADP is basically the one which what you can say collect more and more and more platelets, and thromboxanes A2 are those which basically what you can say form this platelet plug. Okay, so and inside the platelets you can see this yellow things. What are there? What are these yellow things? These are the fibrinogen. What is this? This one is, these yellow small things are what? Fibrinogen. These small things which you can see between the platelet plugs, this is called as fibrinogen. Okay. So this is all about what you can say the primary hemostasis, and the platelet plug is formed, okay, which is the main thing you can say at the end of the primary hemostasis. So basically, fibrinogen is also called as factor 1, okay, and it is a glycoprotein, okay. So now, how it is formed? Simply, it is converted from fibrinogen to fibrin, okay, and of course, uh, different enzymes are also involved. Anyhow, we will go further and we will go back to secondary hemostasis. What is secondary hemostasis? Is basically, it is a process, you can say, which makes the platelet plug um, more stronger. Okay, so what is the aim of secondary hemostasis? Is to reinforce the platelet plug, okay, by simply the production of fibrin clot, okay. So this is like the end result of this thing is what, like there will be the formation of what, fibrin clot. This is the end result of this stage, that fibrin clot should be formed, okay. Okay, now what is secondary hemostasis, guys? It is simply that the fibrinogen which is there between the platelets should be converted into a stronger thing which is called as what, fibrin. See, what is this? This is fibrinogen, okay. This fibrinogen should be converted into fibrin to make this clot stronger. And from where this fibrin comes out, you will see all these things, okay. All these things are involved. Now here comes what you can say, hmm, a little more complicated things, okay, which many guys they found it difficult to understand, okay. So guys, okay, before going to that, I would write to I will write few points over here which will again help you. So one Willebrand factor which was here, it will attach the adhesion with the receptor called as, I told you that time, that is called as what, glycoprotein 1. This is Roman 1, so I will write like this, 1b, okay. So this is like glycoprotein 1b is there, okay. And what you can say, ADP ADP is there, which binds to the receptor which is called as um, glycoprotein glyco GB, glycoprotein GB, okay, yes, 2 2B 3A, okay. This is the receptor which is involved, okay. Or simply what I'm saying is, see, over there, here it will be written over here, yes, where is the receptor? See, it is glycoprotein 2B3A, okay, written in a different form, okay. Maybe here they have written in yes, see, glycoprotein 1B 1 and 2B 2A, and this one is glycoprotein 1B, okay, I was talking about, and this is glycoprotein 2B3A, okay. So when adhesion is there and the platelet attaches to one Willebrand factor which receptor is involved, glycoprotein 1b. This is the full name, of course. And in the process of aggregation, when the platelet plug is formed, the platelet will attach to platelet with which receptor? Glycoprotein 2b 3a. Okay, there are many other receptors, guys, but I'm not going in detail of that. But of course, every receptor have its own function. Okay, which what you can say, I talk about glycoprotein 1b. Okay, because like when you will open the Kaplan's, by the way, so you will found like there is a condition called as Bernard-Sollier syndrome, which is related with that receptor. Okay, then I talk about glycoprotein 2b3a complex. Okay, so basically this is the one, which is which is connected with the other platelet. Okay, and between them, what is there? I show you here. See, this platelet is attaching with this platelet, and in between, what is there? Fibrinogen. Okay, so basically, this is fibrinogen, which is in between what you can say the platelet aggregations. Okay, so simply glycoprotein 2b3a, sorry, 2b3a, yes, 2b3. I always get confused, because 2a, 3b, or so 2b3a is the one which causes platelet aggregation and adhesion to endothelial surface. Okay, now why I am what you can say talking about this thing, because the medications abciximab is the one which we use, okay, to counter this thing. Okay, and see, the aspirin is the one which is going to stop thromboxane. If you remember, see what is needed here for activation, thromboxane A2, right? So that's why whenever we give aspirin, so see, this one is the one which is blocked, right? See, this one will be blocked by aspirin. This one is blocked by what? Abciximab. This one is blocked by teclopidine. So see, that's why the medications are used in this thing. So that's why I was talking about. So that's why I talk about thromboxanes, I talk about ADP, I talk about this receptor, I talk about this receptor, because all of these are those in on which like there are certain medications which act. Okay, okay, guys, remember, uh, you know what is adhesion now, you know what is activation, you know what is aggregation. All these things need one thing as well, that is called as calcium. Okay, so that's why calcium is very important, simply uh, to make a primary hemostatic plug. So this plug is also called as primary hemostatic plug, because this is primary hemostasis. Okay, so calcium is very important to make what? Primary hemostatic plug, right? So now secondary hemostasis. Secondary hemostasis, the main function is what? To convert the fibrinogen to fibrin, right? Now, to convert fibrinogen to fibrin, of course, like to make the clot or that bond more stronger. Okay. Uh, Now, in secondary hemostasis, what is going to happen? Fibrin clot is formed. Okay. There are two pathways. One is called as extrinsic pathway, and one is called as intrinsic pathway. Okay, one is called as extrinsic pathway and one is called as intrinsic pathway. It is also called as initiation pathway, and this is also called as amplification pathway. Okay, so in extrinsic pathway, initiation pathway, like the thing, yeah, the one which is initiating the clotting, right? And intrinsic pathway or amplification pathway is simply once the clotting has started, so it gives the positive feedback so that the clotting should amplify, keep on amplify. Okay, but both this extrinsic pathway and intrinsic pathway, of course, their final result is same. Okay, so what I'm saying, when I will show you the picture, you would understand what I'm saying. This is also called as what? Initiation pathway. Okay, Why? Because this is the one which will initiate the clotting, and this is also called as what? Amplification pathway, because the its job or its work is amplification. Okay, so that the clotting factor, clotting pathway keep on running. So what is the end result of both of these pathways, guys? Both of them, both of them converge, you can say, and onto a common pathway. Okay, I will show you now what I'm talking about. And when they converge into common pathway, that results in what? Thrombin generation and fibrin formation. Okay, so uh, okay, this is the same thing. This is a primary hemostasis, this is a secondary hemostasis. Okay, I will show you now, guys. This is intrinsic pathway, and uh, this is both intrinsic and extrinsic. It is very easy to understand. Okay, and how easy to understand is simply like, there are many clotting factors: factor 12, factor 11, factor 10, factor 9, factor. So it is the same thing: factor 12, factor 9, factor. Okay, but it looks complicated because like all the books, they write it in complicated fashion simply. Okay, so what's going on? See, intrinsic pathway. Intrinsic pathway is the one which, see, injury to blood cells or cells in contact with blood, damage endothelial or exposed collagen. So what intrinsic pathway do? What do I talk about? Amplification. What extrinsic pathway do? It initiate, right? It initiate. See, tissue trauma is going to happen. Okay, tissue trauma is going to happen. Tissue factor is released. What it is doing? It is changing factor 7 to factor 7A. A means activated, which in turn is activating factor 10 to factor 10A, right? Which in turn is activating what? Prothrombin to thrombin. Okay, simply this is also called as factor 2, and this is also called as factor 1. Okay, so the thing is so simple. 7 is activated, which is activating factor 10. Factor 10 is activating factor 2, and factor 2 is activating factor 1. And what is the end result? Simply prothrombin is converted into thrombin. That's what we want. Okay, what is needed? Calcium. What is needed? Factor 5. Okay, wait. um, Intrinsic pathway. Factor 12 was there. Blood trauma or contact with collagen happened. It is changed into activated factor A, factor 12A. That will in turn activate factor 11. See, 11A is activated. That will activate factor 9. Factor 9 will change what? Activate what? Factor 10 to 10A. Now see, both of them, they are same over here. What extrinsic pathway was doing? 7 is changing 10 to 10A, activated. What intrinsic pathway is doing? Whatever is going on, but the end result is what? Factor 10 is activated to factor 10A. End result is same. Again, calcium is needed. Okay, and see, once 10A is activated, rest this one and this one is common pathway, and together when we combine these pathways, it will come back as this. 12 to 12A, 12 activated will activate 11. 11 in turn will activate 9. 9 will in turn activate 10 to 10A. And to do this, what they need? Factor 8. Okay, there should be a presence of factor 8, which is activated by thrombin. Intrinsic pathway C 7 to 7A, which in turn will activate what? 10 to 10A. Calcium is needed. So both extrinsic and intrinsic pathway will converge together. And what is the final thing? What we want is, we want prothrombin to change in thrombin, okay, and thrombin will change into fibrin. So simply thrombin will change fibrinogen to fibrin. And what is this? If I will tell you in very 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 simple words, now come back to this one. Which pathway is this one? Extrinsic pathway. Okay, this one is which one? This one, factor 7. Factor 7 came in which pathway? Extrinsic pathway. So this is extrinsic pathway, okay, and this one is intrinsic pathway. Whatever is there, the final result is to change factor 10 to activated factor 10. Calcium is needed, which will go, and in turn it will change prothrombin to thrombin. Thrombin will change fibrinogen to fibrin. Okay, so simply, when fibrinogen was there, and when fibrinogen is changed into fibrin, that means the clot is now stronger. And to tell you in a very very simple words, guys, basically there is nothing more than, there is formation of these cross stabilization, like you can say a meshwork or a network of what you can say, this thing is formed, okay, between all the fibrinogen, okay, which basically change fibrinogen to fibrin, okay, and what will happen, like all this clot is stabilized, becomes strong. This meshwork or this cross linkages will simply, see, cross linking stabilization. So what's going on, like all what this process is doing, it is just making cross linkages and making the clot more and more and more stronger, okay, and that's what we needed. So that is basically secondary pathway, okay. Now few concepts, by the way, which are very 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 easy to understand again. These are all the factors. See, fibrinogen, which we are talking about again and again, guys, fibrinogen is the one which is also called as factor 1, and prothrombin, factor 2, is also called as prothrombin, okay. So see, here factor 2 is converting to factor 1, right? Or fibrinogen is factor 1. So simply, see, conversion of prothrombin to thrombin. Prothrombin is circulating in the blood. Prothrombin activator is there. Calcium is needed. It will change into thrombin. Thrombin will change fibrinogen, which is between the platelets, to fibrinogen monomers. Calcium is needed. It will change into calcium fibers, which will make cross-linked fibrin fibers. What I draw over here, cross-linked fibers, okay, and make this clot stronger. So that is secondary hemostasis. That's it, okay. So once this cross linkages are formed, so the job is done. Now the clot is stronger, okay. Now the clot will hold the blood, not allow the blood to leak or not allow the clot to break off, okay. Okay, now very important things, guys. Okay, this is also called as clotting cascade, okay. Few clinical points which are very 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 important to remember. Extrinsic pathway can be stopped or can be blocked by giving, see, extrinsic means outside. Outside war can happen. So remember, warfarin can block all this pathway. And if you remember, Uh, See, when someone have, for example, uh, pulmonary embolism, okay, someone have DVT, someone is putting heart valves, mechanical heart valves inside. We want in them so that there should be no clotting cascade. So we give them warfarin, okay, so that no clot will be formed. Now, warfarin block the extrinsic pathway. If you will see over here, guys, okay, what it means: factor 7, factor 10, factor 2, and factor 1. Okay, all these can be blocked by what you can say warfarin. Um, okay, to make the things easy, if you know warfarin, basically, the extrinsic pathway is vitamin K dependent. They need vitamin K to form all the extrinsic pathway, uh, you can say, factors. So factor 10, factor uh, 9, factor 7, factor 2, okay, all these things, they need vitamin K um, to form. And what is the function of warfarin, by the way, guys? What is the function of warfarin? Basically, you can say vitamin K. Very easy to remember. Vitamin K is converted to activated vitamin K by which enzyme? By enzyme called as I think epoxide. Maybe I'm wrong, but just check the spellings, okay? Because I don't want to open something and what you can say, just to check the spellings, So epoxide oxidase. So warfarin basically block this enzyme. Okay, so warfarin blocks this enzyme, and when this enzyme is blocked, what will happen? All these clotting factors will not form, and when the clotting factors will not form, what will happen? That there will be less and less clotting. Okay, so anyone who have like over clotting, like they are clotting too much, we can give them warfarin to stop the clotting. One mnemonic which is used is like 1972, the war between Canadians and Soviets. Okay, so just make a small change in this one. 1972, basically 1 is 10, so factor 10, factor 9, factor 7, factor 2, protein C and protein S are all vitamin K dependent. Okay, and that's the reason whenever we give them warfarin stops the extrinsic pathway. So what happens is simply warfarin blocks all this. So block, first of all, warfarin blocks protein C and protein S. So that's why whenever we start warfarin, first the patients go into a little phase of hypercoagulability and then they become hypocoagulable. Okay, so and how we can check the action of warfarin? By measuring PT, prothrombin time, okay, which is also called as INR, international normalized ratio. Simply, very easy concept, guys. Not so hard, not so difficult. Okay, so this one is about warfarin. So warfarin we use what for? What we use for? To stop the extrinsic pathway. Okay, now intrinsic pathway, which is, the function of which is amplification. Heparin, we give heparin to counter this pathway. And that's why, whenever someone have myocardial infarction, they put them on water heparin. Why? Because someone who have pulmonary embolism or DVT, because they don't want this amplification. They want to stop this amplification. So guys, remember intrinsic pathway. All this intrinsic pathway can be countered by what? Heparin. Okay. So simply, you can say basically what happens. That there is antithrombin, which is converted. What you can say, which antithrombin is there. Wait, I will show you. See, uh, heparin. Okay. Or wait, in the other one, I think like they have given in a good way. Okay. So yes, whenever we give heparin, it basically counter or it stops all this factor 12, 9, 12, 11, 9, and 10. Okay, so all these things can be stopped by giving heparin. Okay, so whenever what you can say, whenever we want to monitor the functionality of like either how the heparin is working, either it's working or not, we measure what? Uh, PTT. Okay, PTT, we measure have PTT for heparin. Okay, so PT for we measure for warfarin, and PTT we measure for what you can say heparin. So this is what you can say is a secondary pathway. So see, in primary pathway the main player is platelets, okay, and von Willebrand factor. In secondary pathway, the main player is all the clotting factors. Okay, and then there is fibrin stabilization, uh, which is again what you can say one of the thing which occurs, you can say, in clotting. Um, in fibrin stabilization, what is there? What is there? Simply, this is the conversion from soluble. It is a conversion from soluble to insoluble and stable clot. Okay, like this is also a stage, and of course, like what is fibrinolysis, guys? Um, as the name shows, once the healing is done, once the patient, like once the thing is done, once one the target is reached, okay, or once the healing is initiated, so the clot should dissolve. Okay, so this is simply clot dissolution. Okay, and how? Again, there is a fibrinolytic system which is there. But again, like I think like I put a lot of time just to make you understand these things. See, different what you can say drugs, they act on different stages. For example, I told you that um, simply you can say platelets activation can be stopped by giving aspirin, which will affect on hair. Okay, then we give glycoprotein 2b 3a inhibitors we give, right? So what is glycoprotein 2b 3a inhibitors? I told you the drug called as AB6Z okay. Then there is ADP inhibitors, okay. Then there is ADP inhibitors, we can give to the patients, okay. So ADP inhibitors, what you can say, are used in clinical medicine, of course, and like all these drugs, you can say, which we give to the patients, like clopidogrel, okay, ticlopidine, and all these drugs, they stop the platelet activation. And I told you about the secondary pathway. The main thing is to change fibrinogen into fibrin or a strong clot. Okay, so what you can say, basically, I did not talk about many things, but why? Because for example, I did not talk about kininogen or this one high molecular weight, I think kininogen. Okay, so high molecular weight kininogen, I did not talk about these things because they are not like We like no medications will come on our way when we will discuss that. Okay, so antithrombin is the one, like heparin is going to stop that. Of course, we give heparin and to stop all this thing. There is one drug called as dabigatran we give to the bleeding disorder patients. We give, for example, fundo perinox. We can give low molecular weight heparin. Okay, so remember uh, all these drugs, aspirin, clopidogrel, AB60, all this one, they act on primary platelets. And warfarin, heparin, or low molecular weight heparin, or dabigatran, and all these drugs, they act over here. Okay, so PT, I told you we will check the activity of warfarin, whereas APTT we measure to check the you can say action of heparin. Okay, so and of course platelet count we can check, like either the platelet count is there, like the platelet is normal or not. Okay, so remember, like what you can say, PT have PT for serpentine, T have single T. Okay, so tennis is played outside extrinsic pathway. Warfarin, war is outside. And if we will talk about PTT, so there is double T. So table tennis is played inside, so intrinsic pathway. So heparin. Okay, so PTT is for intrinsic pathway, whereas PT is for extrinsic pathway. PT is also called as INR. So PT we measure to check the activity of warfarin, and APTT or PTT you can say we check to measure the or to monitor heparin therapy. For example, so if you are giving anyone uh, heparin, you will activate it through a plasma time. You will check. Okay, if you are giving someone warfarin, you will check PT or INR. It is also called as INR, international normalized ratio. We check INR. Okay, this one, this thing we can check in the patients to check the function of this one. Okay, so now what you can say, if you understand these things, guys, like what is the end result? Like we have to make fibrin formation. Uh, like I will tell you now why it is important to understand like these things is simply uh, okay. So any platelets disorders, okay, which could be any, okay, uh, they remember they results in superficial bleeds. Okay, superficial bleeds. What kind of superficial bleeds can be there? Petechias. Remember petechias. See, it's a superficial bleed. Okay. uh, purpura is of, like the bigger one. uh, ecchymosis, okay, or for example epistaxis, the bleeding from the nose, or in females for example menorrhagia, okay, like increased bleeding during menstruation. So petechias, purpuras, ecchymosis, epistaxis, menorrhagia, like all these things are what you can say uh, superficial bleeds, nose or on the skin. For example, I will show you over here how petechia look like. See, superficial bleeds are there, right? This is hematoma, bleeding in the joint. See, the joint is too much enlarged, so this is bleeding in the joint. So this is superficial bleed. This is deep bleed. So whenever there is superficial bleed, I'm not talking about deep bleed. Superficial bleed like this. See, petechias, superficial bleeds. Okay, this is deep bleed, hemarthrosis, like in the joint. So I'm just talking about superficial bleeds like petechias, purpuras. Okay, again they are, or ecchymosis. See, superficial bleeds. So all the superficial bleeds, again this is Hinox colon purpura, we already have studied this one in pediatrics, ecchymosis. Superficial bleeds, platelets, remember guys, they cause superficial bleeds. Platelets cause superficial bleeds, okay? If you remember this thing, things will become easy. So whenever anyone have superficial bleed, what you will do? You will order CBC. And in CBC, what you are going to look at? Platelets counts. Okay. What can be the condition? Number one condition can be low platelets. Okay. Or the other condition can be platelets normal. Okay. So of course, when the platelets are low, it means like the platelets are low, and that's why the patient is having this thing. But if the platelets are normal, what it means, like, you know, the platelets are there, but they're not functioning fine. Okay. So what are the conditions in which the platelets can be low? For example, see, different viral infections, dengue, you know, it causes thrombocytopenia. When the platelets are low, you know, of course, we call it as thrombocytopenia, and there is increased bleeding time because no platelet plug will be formed. So what will happen? You can say there will be bleeding time will be increased. Okay. So viral infections, in pediatrics we already covered immune thrombocytopenic purpura, thrombotic thrombocytopenic purpura, hemolytic uremic syndrome, heparin induced thrombocytopenia. When we give heparin, it can cause thrombocytopenia. Immune thrombocytopenic purpura, thrombotic thrombocytopenic purpura, hemolytic uremic syndrome, heparin induced thrombocytopenia. If the platelets are normal, it means like the platelets are normal, but of course they are not functioning normal. Number one, it could be aspirin therapy. Anyone who is taking aspirin, you know, they will present like the platelets will be normal, but thromboxanes A2 is decreased, so the platelets, they are not functioning well. Uremia, when the urea is like too much in the body, what will happen? They are going to cover the platelet surface. Platelets are there, they cannot attach together. Okay, I told you a condition called as Bernard Solier, maybe the spelling is not correct, okay, syndrome. So in this one, what happened? Like there is deficiency of glycoprotein. I told you 1B. These are the glycoproteins which are used to attach. Okay. Then there is one more called as Gansman thrombocytopenia. What happens in these people? They have abnormal glycoprotein 2B3A. Now see, these are the needed for the platelets to attach with each other. They are not there. One more thing, for example, there is no Willebrand factor or Willebrand factor deficiency. Many people, they have this thing. Okay, see, all these things, platelets are normal, but they are not functioning. For either there is a receptor problem, either they are taking certain drug. Of course, there will be less thromboxane A, not 2. Okay, so this is like how they will present. I hope you understand this thing. This is not a very difficult concept, guys. It's quite easy concept. Okay, one more thing now. The last thing for this lecture is coagulation defects. Now, whenever there is coagulation defects, guys, in platelet defects, what is happening? The patient have superficial bleed. Now, whenever there is coagulation defect, remember the patient have D bleeds, hematomas and arthrosis, okay, hematoma and hemarthrosis. So see, hemarthrosis inside the joint. Inside the joint, the joints will be swollen, hematoma formation, deep bleeds are there, right? Deep bleeds are there. So the people who have this problem, of course, like it means like who will present clinically with these things, hematoma and hemarthrosis, we go for labs and we now check up. See, now it means coagulation problem is there. When coagulation problem is there, see, you will check PT, you will check APTT, you have to check intrinsic pathway, you check the extrinsic pathway, you will go for bleeding time, you will go for LFTs. Why LFTs? Because all the clotting factors are formed in the liver. Okay, so see, what are the conditions? Remember guys, hemophilia A is there, hemophilia B is there, and I think like this is something which we are studying from our previous. C is there, not so common by the way. Hemophilia A, like which factor is deficient? Factor 8. Hemophilia B, which factor is deficient? Factor B, factor 9, sorry. Hemophilia C, which factor is deficient? Factor 11. Okay, and hemophilia A, B, C is not so common. Okay, so for example, there can be vitamin K deficiency. When vitamin K deficiency is there, what will happen? All the extrinsic pathway will be disturbed. PT will be raised, and APTT will be raised, but not too much. Why? Because vitamin K affect most of the extrinsic pathway clotting factors. So all of them, they will be disturbed. PT will be raised, but just one or two extrinsic pathway, okay, what you can say intrinsic pathway clotting factors, it disturbs. So APTT will go up, but a little less. For example, someone is taking warfarin therapy. For example, someone have liver disease. Okay, add here one more thing, renal function test. Okay, because kidney problems can also make you lose proteins, and of course bleeding disorders. So liver disease like cirrhosis or kidney renal failure can be there. Okay, so of course like so guys, remember, excessive prolonged bleeding, okay, think about one Willebrand factor, think about platelets, think about primary hemostasis. Normal, when for example someone have a cut on the skin and bleeding is not stopping, so remember about primary hemostasis, remember about platelets, remember about one Willebrand factor. Okay, for example, someone who have deep bleeds in the joints and the muscles, think about coagulation disorders, okay, or secondary hemostasis. Okay, someone who have too much hyperstaxis, too much menstrual loss, think about primary one. Someone who have petechia, ecchymosis, think about primary one. Someone who have hemarthrosis, hematomas, think about secondary one. Okay, so anyhow, like in the next lecture we are going to discuss a little more about this one. Okay, and I will show you a lot of photographs as well. I hope you understand like much of the concept. Thank you so much guys.